Hey everybody, we're going to start by I'm going to share my screen while everybody gets comfortable. Here we go.
Looking good.
All right, I think we're there.
Let me introduce you to Amanda. You're just meeting her for the first time, but chances are you're already making assumptions about how much she eats and how little she exercises because she's obese. But I'm about to show you that there's much more than meets the eye when it comes to obesity. There are lots of Amandas out there and they need treatment. Maybe you're one of them, or maybe you know an Amanda. It's time to act on obesity. But in order to do so effectively, we need to understand obesity. It's generally accepted that body weight is determined by a pretty simple formula. We call it the energy balance equation, and it works like this. If the number of calories that you consume equals the number of calories that you burn, your weight remains the same. If you consume more than you burn, you gain weight. And if you burn more than you consume, you lose weight. Most people think that those of us who properly manage our energy balance remain lean, whereas those of us, like Amanda, who eat too much and exercise too little, become obese. We view obesity as a lifestyle choice, and the cure for it is simple: eat less and exercise more. This may sound logical, but it's wrong. Let me explain. First, let's talk about set point. No, I'm not talking about the point in a tennis match when one player is about to beat the other. I'm talking about a theory that says that no matter what you consciously want your weight to be, your brain has its own sense of how much body fat it should have on board, and it has a complex system in place that very precisely regulates your energy intake and expenditure to keep you within a so-called set point range for body fat. So that whole energy balance equation, it's not something that you control voluntarily. Your brain regulates your calories in to your calories out for you. For your brain to do this, it needs to know how much energy you have on board at all times. And it knows this by listening to hormones like leptin, which is made in your body fat. You can think of it like a car. Leptin is the gas gauge that tells your brain how much gas is in your tank. But leptin is just one piece of the puzzle. You've got a whole bunch of other hormonal signals and sensors that are involved too. Your bones, muscles, pancreas, liver, GI tract, and sensory organs, they all play a role, communicating with your brain to give it the information it needs to do its job. But that's more detail than we need for this conversation. The point is that you have a complex system in place that regulates you to within a set point range for body fat. So what happens if Amanda decides to lose weight by going on a diet? After all, people with obesity should eat less, right? Here's what happens. She loses weight, but her hormone levels change. Her brain hears this, and it starts acting to restore whatever body fat she's lost. She feels hungrier, and although she doesn't know it, she's also burning fewer calories than before. You see, set point is usually a one-way street. Once it's been elevated, the brain works to defend it just as vigorously as it would a lower set point. Amanda's brain doesn't know that she needs to lose weight. It only knows to defend her current set point. Back to our car analogy. Amanda can't help but look for a gas station to refuel when she sees that her gas gauge is low. At the same time, she becomes more fuel efficient, burning less energy than before. This might explain why treating obesity with diet and exercise so often fails to produce the desired results. It's sort of like telling Amanda that she needs to be a more careful driver, when the real problem is that she needs a mechanic to fix her car. Okay, so if we've all got this complicated system in place that prevents us from losing weight, why doesn't it also protect us from gaining weight and developing obesity in the first place? How can we explain the obesity epidemic? Getting back to Amanda, why did she develop obesity? The answer is that it takes a perfect storm to cause an obesity epidemic like the one we're seeing now. And it's our modern environment that places us, and Amanda, directly in the path of that storm. While there's no single cause for the rising rate of obesity, changes to the chemical and nutrient content of our food, the so-called Western diet, a decrease in physical activity, increased levels of stress, inadequate and disrupted sleep, and more widespread use of medications that promote weight gain all play a role. Our unique genetics and developmental histories cause each of us to respond differently to these elements of the modern environment, and some of us, like Amanda, respond by sending hormonal signals that elevate our set point for body fat. It's not that Amanda's system has stopped working. It's just that it's working to regulate her to a set point that's too high. So you can think of obesity as a biological response to the modern environment, a disease where the body dysregulates to a body fat set point that is too high. Back to our car analogy. The size of Amanda's gas tank has expanded, so she carries around too much fuel. For Amanda to lose weight and keep it off, she needs to find a way to lower her set point. That is, rather than declaring war on her own biology, she needs to find a way to make her body regulate itself to a new, lower weight. One option for Amanda to consider is bariatric surgery. In study after study, it's been shown to be the most effective long-term treatment of obesity. But how bariatric surgery works is often misunderstood. Most people, even many doctors, think of bariatric surgery in terms of restriction or malabsorption. It's a reasonable assumption that surgery would work in these ways. After all, the procedures usually consist of some combination of altering stomach anatomy to be smaller, which you'd think would restrict the amount of food that you'd be able to eat, and rerouting the GI tract in a way that you'd think would make you fail to absorb the calories that you do eat. But new research suggests that certain types of bariatric surgery, for example, gastric bypass, sleeve gastrectomy, and duodenal switch, affect the signals between the brain and the body to decrease appetite, increase feelings of fullness, increase metabolism, and even encourage preferences for healthier food. Surgery may change the set point for body fat. It's like the anti-diet. Instead of fighting the set point like a diet does, surgery may recalibrate it, and the hormones that stimulate weight gain when a person diets do the exact opposite after surgery as the body regulates itself to the new lower set point. So here are 3 things you can take away from all of this. 1. Energy balance is complex and highly regulated. 2. Obesity is a disease where the complex system that regulates body fat may dysregulate to a set point that is too high. 3. Bariatric surgery may work by changing the signals that regulate body fat set point, enabling patients to successfully lose weight and keep it off. It's time to reshape the conversation about obesity. It's time to look past diet and exercise as the only treatment solutions. It's time to act on obesity. And now that you've been educated, here's a simple way for you to act. Share this video.
All right, everybody. John, is that all coming through okay? And can you all see me all right?
Looks great.
All right, great. Well, welcome to the seminar. My name is Robert Woodbury. I'm the medical director of the team, and today we're going to do a whole education around the disease of obesity and the treatment. And I'm going to go through a wide range of topics, and it'll go pretty fast. And don't worry if you don't get it all the first go round. We'll have a recording on our educational website that you can kind of go back on and look at and study up on it. So the goal today is to just kind of get around the whole topic. So we'll start with definitions. And this has to do with body mass index. The body mass index is the way we can compare height of somebody versus their weight. And then that gives us a reflection of disease burden or absence of disease burden. So for example, if you're 6'1" and you weigh 265 pounds, your body mass index is 35. If you're 5'7" and you weigh 254 pounds, your body mass index is 40. And if you're curious about your own, you can use a calculator, or even your phone will probably be able to just tell you nowadays. So once we know the body mass index, there are classifications of health, with normal being basically 19 to 25, overweight is 25 to 30, obesity is 30 to 35, severe obesity is 35 to 40, and morbid obesity is 40 or more. And that morbid obesity word is a pretty strong word, but that has to do with how much risk that level of body mass index has. And then now you can graph, based on the body mass index, the patient's risk of disease and even their risk of mortality. And if you look on the graph, you'll see obesity, remember, is in that kind of 30 to 35 range. You can see that's the yellow zone. We start to see the mortality rise. And when we get to a BMI of 40, and you look up That's the risk of mortality. And there are many, many so-called comorbid diseases. Those are the things that go together with this disease of obesity. So, what is it about obesity? Fundamentally, it's a metabolism disease. That's a way of thinking about that. And then the set point is a very helpful concept, which is how much your brain thinks, how much energy in the form of fat it thinks it needs to store. And that's why when you eat more, it might burn more. If you eat less, it might slow down. Unfortunately, changing the set point is hard. Obesity is a chronic inflammatory disease as well. It's associated with literally changes in the bacteria inside the intestine. And literally, there's a genetic component to it that we'll get into in a little bit. Then there's the whole psychology and around our society and body image, that kind of thing. That's all put together in the disease of obesity. The result of all this is excess energy storage as fat. The fat itself is not the disease. The fat is the result of this metabolic disease that keeps the body and convinces the brain that it needs to continue to store energy as fat. So it's complicated. This is not just a willpower problem. That whole idea that we can consciously decide, about our metabolism, it really is regulated at the brain level. Their genetic component has to do with what's called the FTO gene. The FTO gene is, it's not like a blue-eye gene or a brown-eye gene, where like if you have that gene, you're going to have blue eyes or brown eyes. The FTO gene sets a patient up for more efficient energy storage, and actually reward centers in the brain are altered. And so the FTO gene doesn't mean one has to become obese, but it really sets a patient up. And one of the things has to do with the patient's satiety signal or their stop eating signal. And if you have the FTO gene, literally on brain imaging, your stop signal is not as strong as others. You don't know any different. If you have the FTO gene, you just know your stop signal or you have no stop signal. And other people, they have a strong stop signal, they can stop eating, and they don't know any different either. So it's very interesting, this genetic component. Now, hormones are the way the body's guts and its fat talk to the brain. So when you hear me say hormones and metabolism, they're kind of generic words, but that's a way of thinking about it. And what happens is when you just put somebody on a low-calorie diet, their hormone changes and their metabolism slows down, and the body gets very good at storing fat. It doesn't want to give it up. And you keep starving the body and you keep putting them on these very low calorie diets, and it keeps holding on. And eventually the patient does start losing weight, and it loses weight in fat and muscle. But now, if you eat just a little bit more again, because of the hormones and the position they're in, the weight comes roaring back, usually more than the patient started with. And the weight that the patient gains back is all fat, not the muscle again. And this is the yo-yo dieting that results in a progressive rise in the total body weight. This is all hormonal related. And these are just some of the things around the disease of obesity. It's more complicated even than that. So how do we approach a treatment plan of such a disease? And the answer is we have a pyramid. So it's not just one thing or the other. We start with the fundamentals, which would be lifestyle like nutrition, exercise and activity, stress management, sleep, and overall wellness. These are the fundamentals. We have to have them in place. And as the disease burden gets worse, we're into the obesity section of that body mass index, we start to consider medical treatment. And then for patients suffering from morbid obesity, we talk about metabolic bariatric surgery. And it's not that one is better, good, right, or it's not one or the other or the other. It's an additive kind of treatment plan. Okay, we're going to talk a little bit about lifestyle fundamentals around nutrition, exercise, and stress. And Let's start with the eating. How should we eat? There are many diet books out there, obviously, and they have good, solid information in them. The problem we found in treating patients with this disease is you can't just hand somebody a book and say, go do this diet plan, because everybody's life is individual. Now, that being said, there are some fundamentals that are really non-negotiable, and this applies to everybody. So the first thing is counting nutrients, not calories. And people are very surprised when they start in our program, and we don't put you on a very low-calorie diet plan. We're more focusing on the types of foods, very nutrient-dense foods, and eventually we get to reducing the calories, but that's not how we start. We focus on a balance of proteins and vegetables and healthy fats. So we don't put people on no fat diets. In fact, quite the opposite. There's a combination or a concept called glycemic load, which is also very important that applies to everybody. And that is when a person eats food and then that food gets digested. The body turns it into blood glucose, blood sugar. The glucose goes around the bloodstream and feeds the muscles and the organs. That part is good. Now, some foods spike the blood sugar really high, really quick, and then it drops off. And other foods kind of bring the blood sugar up a little bit, but over a long time. This is very important. If your body is good at storing energy. And for people that have obesity, you store energy well. If you give the body too much blood sugar too quickly, it's going to take all that blood sugar and store it as fat, no matter how much you wish it wouldn't. There are some people that have a metabolism that if you eat a higher glycemic food, the body metabolism will be raised. These are the people that can eat what they want and they don't gain weight. That is not because they are morally superior. They have a different metabolism. So, some of the examples of this glycemic load business. There are healthy foods that have a high glycemic load, like bananas and potatoes. And initially, when we're in a weight loss phase, we take these otherwise healthy foods away from a person, not forever, but we have to really focus on in a weight loss strategy, we have to eat low glycemic foods. For a health strategy, never mind weight loss, we need to get rid of sugar. This stuff is hazardous and it's addictive. And there are centers in the brain. It's not just addicted to the taste. There are brain reward signals that are involved in the sugar addiction. And the food companies know this. And that's why they put so much sugar in it. And it's hidden everywhere. Okay, general eating principles. We try to acknowledge that food is going to be nurturing. We have food with celebrations, happiness, sad events. The invitation is how do we nurture ourselves with high quality foods, small amounts of really good food rather than large amounts of really junky food. And it's an invitation. I invite myself to remember that all the time. There is a concept called intermittent fasting, which before it became that fad diet, we've been doing it called adjusted time eating for now nearly about 15 years. And this has to do with the eating window and the timing that a person, a human, is ingesting food versus not. And it actually matters. And for some people, we will narrow that time window for eating. If your body's good at storing energy and you eat a giant meal, just like the glycemic load, your body's going to take that energy and store it as fat, no matter how much you wish it didn't. Alcohol intake's important because it's a toxin and it also has a very high glycemic load. Avoiding dehydration, we think this is my cue. That's lemon water. It doesn't mean a person needs to flood themselves with water, but we want to avoid dehydration to run a healthy metabolism. Okay, stress. Lots of people are under stress. It's a byproduct of our society. Having acute stress is good if you're running away from danger. I always say you're running away from the bear in the woods. You want to have a lot of stress. Well, what do we mean by that? Well, we want a lot of blood sugar, right? Because those muscles need a lot of energy. So We want the body to swing the blood sugar up. And then there's an inflammatory response that there are good sides of inflammation under trauma stress, but they're bad when we're talking about energy storage and function of healthy fats. And then stress triggers signals in the brain that are also altered. And the thing is, if you're actually running away from a bear in the woods, this stuff is good, but your body cannot tell that. They can't tell whether you're running away from the bear in the woods or you're just commuting on the freeway to work. You get that same biochemical stress response, very, very strong, and we do not have a treatment that can overcome it. Here's another non-negotiable thing. Has to do with exercise and activity. It's very important. Both are important. And for exercise itself, the issue is how to create the time and space in one's life. We try to invite ourselves, I invite myself to make it nurturing, make it most days of the week, do a combination of aerobic and resistance training. That muscle training and building strong muscle is very important for weight management. Okay, so we kind of did hit the high points of lifestyle. And how do we know this stuff works? There's plenty of scientific evidence. You don't need to go to reading some fad diet plan. This is New England Journal of Medicine caliber research on lifestyle and blood pressure and pharmacology and diabetes treated with these lifestyle interventions that we're talking about. The nutrition research is all there about the Mediterranean diet and vascular inflammation and low glycemic load. It's all in there. And this is, if you really want to geek out, each of these references is on our educational website if you want to go see the primary data yourself. Okay, so that's lifestyle, that's fundamentals. Now we're going to switch into medical therapy. So now if we have a patient suffering from obesity, body mass index of 30, maybe 28 or 29, if you have really bad high blood pressure, diabetes, we start to add medical therapy. How do we decide? The way we decide any medical therapy, it's what's the risk of doing the therapy, what's the risk of the obesity, and what's the chances of succeeding without a medication. And so the balance runs around a body mass index over 30 with medical conditions. The risk of that is quite high, and it balances the risk of the medication. So the criteria in general, again, I've said this body mass index over 28 with medical conditions like high blood pressure and diabetes could be a candidate for medication. That doesn't mean everybody has to have a medicine, not at all, but the balance of the risk benefit starts to be present. We've got to have nutrition and exercise plans in place, pregnancy, basically all the medications you can't take while you're pregnant. There's a couple of minor exceptions, but the ones we're talking about cannot be taken while you're pregnant. And then everybody needs a primary care doctor to coordinate care with. And long term, just like long term in any other medical condition, is still at your primary care office. How do we choose? And we would recommend a weight loss medication based on medical factors and risks versus benefits. So, we're going to go through the general categories of weight loss medicine now. And the first one is the sympathomimetics. And this is the phentermine, is a classic example. Now, some of the older dosing in phentermine was much higher than we need now. The older doses started out in the 37 range, but we know we can go way lower that, and most people respond well. There's a combination medicine called Qsymia, which combines low-dose phentermine and topiramate. And these things give a slight boost to metabolic rate. In the doses we're talking about, it's not like amphetamine boosting. And it helps enhance that full signal. So these are some older medicines, and there's still a role for them. Now there's some central acting medications, and this is where we get into the classic is naltrexone combined with bupropion. Naltrexone helps blunt reward centers, And Wellbutrin helps regulate norepinephrine and dopamine systems. And the classic medication is Contrave, which adds both of them together. It's quite good, actually. And there are some contraindications for these medicines as well. These are the fancy new ones that everybody hears about. These are the GLP-1 medicines. Also, we call them the hormonal medications. And these are medicines that mimic naturally occurring hormones in our body. And now we can add a analog to these hormones. And GLP-1 is one of them. GIP is other. There's a couple coming on the market that are going to affect amylin and glucagon. So this is an exciting area of medical research. The way that we kind of think about how they work metabolically is they affect the gastrointestinal function and blunting hunger, decreasing appetite, and they also help insulin effect. So you can get the same effect with less insulin, which is a great thing because if your insulin is high, it's responding usually to blood sugar, but it also is telling you to store energy as fat. So you don't want to have a high insulin level. And these hormones help get the same effect with a lower insulin level. It's kind of a way of thinking about it. So that's how they work. Now, the side effects are a bit longer in some cases that we have to worry about for the newer medications. And one of the important side effects can be disruption of our native hormones. So our bodies naturally make these GLPs and GIPs and glucagon. And when you start giving extra hormones, that alters the body's native system. And this is very important if somebody is going to have surgery because the surgery actually enhances the body's native hormonal state. The other thing about these very powerful medicines is the anorectic effect is quite strong, and there's a risk of losing too much muscle. There are practical concerns around costs and insurance authorization problems. And what people need to know is we don't have any way of forcing your insurance to pay or not. We can make recommendations, but we don't have any control about people's insurance. And it's been changing month by month. It seems to change which hormone their patient's insurance will cover or not cover. And the patients you need to get directly involved. They need to get directly involved themselves often in dealing with their insurance company. How do we decide which of all these various medicines? Don't go deciding yourself. Think of it like this. If you had high blood pressure, you wouldn't go home and try to decide whether you want to take lisinopril or metoprolol. They work different. We'll help guide you through the decision and with your primary doctor of appropriate use and which medication. The biggest concern about the stronger the medication, that the patient can end up eating so much they become into a starvation effect. And then we're back to the same problem of the body is holding on, their hormones are trying to fight it. You have to increase the amount of the hormonal medication, and the body starts losing too much muscle mass. And then, if you let up just a little bit, you run the risk of gaining weight back, and then the weight that you gain back is fat. So, we want to these hormonal medications require coordination, and especially for the first few months, we think our group can help people and their regular doctors, get that going in proper balance. Okay. Now, when do we talk about surgery? We talk about surgery with the disease of morbid obesity. Now that body mass index is 40, maybe it's 38 with bad comorbidities. Remember, for medications, it's greater than 30 or maybe 29 if you have bad diabetes and hypertension. For surgery, it's now 40 or maybe 38, 39 with bad medical disease. Now we're talking more surgery. How do we decide what surgery a patient needs? The same way we decide the medicines. We say, what's the risk of the treatment, in this case, surgery, in each patient, and the risk of the morbid obesity disease, and what is the chance of um, achieving long-term success without surgery. This concept of balance goes back to the National Institutes of Health in 1991. And I remember when this came out, how to think about who should have surgery or not. So this is the criteria. So remember, body mass index over 40 or high 30s with bad other diseases. We've got to have a primary care doctor for us to coordinate with and being prepared to attend a longer term follow-up. There are exclusion criteria. We are a fantastic program, and I've been doing bariatric surgery for many decades now, more than 30 years, I think. But some patients are very sick and very big, and they need to go to a more of a university level of care. So those exclusions tend to be people in the very high body mass index, high 60s or 70s. Now we're talking 550, 600 pounds, that kind of a patient. It's a very high disease burden. The other exclusion criteria is smoking. So this is a health program, so we need to have people quit smoking 3 months prior to starting the intensity of a preparation for bariatric surgery. And for those people that are still smoking, you can get with your regular doctor. There are medications to help, and then come see us at support group. That's how we'll support you while we wait for you to get through that phase of your healthy journey. Same with active substance abuse. And then also the thing to remember is a surgery program is a longer term commitment to follow up than, say, a medical program. For some people, they just are not, that's just not what they want, and they're not interested in the long term. And so that they're better served in a different program because we're more interested in that long term follow up and health. We'll go through a couple of the different surgeries that we treat people with in our program. And mainly it's gastric bypass and sleeve gastrectomy. We'll learn about some others. We especially like the gastric bypass for people who have really, really bad diabetes or really bad gastric reflux, like acid reflux. That tends to be improved with a bypass and made worse with a sleeve. On the other hand, with the sleeve gastrectomy, we tend to like that if people need a lot of non-steroidal anti-inflammatory drugs, which if you have sore joints, it's a good medicine, but it can cause ulcers. In the sleeve stomach, there's no increased risk of ulcer on these medicines, but in a bypass there is. So it's a little something you have to be very careful with. The sleeve is a little simpler in follow-up and it has slightly less metabolic power. And for most people, that power difference is not anything that matters too much. So we'll talk about each of these in detail, but we'll also touch base on other surgeries, including the gastric band and the duodenal switch. So here we go. This is Roux-en-Y gastric bypass. We'll take a look at this. So we use little incisions, laparoscopy, cameras and long instruments that go through the abdominal wall, and now we can operate on the inside. The gastric bypass, we make a small stomach pouch. There it is. And we leave the rest of the stomach inside you. And we go down and we disconnect the small intestine and we bring it up. And if you imagine it, you can maybe imagine there's a Y of Roux-en-Y. Now, blue is food and yellow is digestive juice. Do you see how they don't meet yet? They're separated. And then now they come together and we start to get digestion. So that yellow part is the bypass part. The other thing to know is that little pouch, that connection to the little bitty stomach we leave behind. And when we connect it to the intestine, we make that very small, pretty tight. And we'll come back to that a little bit later. So this is the Roux-en-Y gastric bypass. I still view it as the gold standard, and that doesn't mean it's the right operation for everybody, but it means that it is of the operations. It's been tried and true for decades and decades and decades. Very predictable success. There is some cost to it. There are some deficiencies in vitamins. Alcohol is absorbed too much. It's not reversible. And there are variations if you Google this stuff around Roux-en-Y gastric bypass or one anastomosis gastric bypass or mini gastric bypass. Those variants are valid, but this is the standard one that we're doing today for general education. This is the vertical sleeve gastrectomy. So here now we have the little incisions again, and this one's a little easier to imagine in your head. So what we're going to do is we're going to create a tubular stomach that transitions to the pumping stomach appropriate and remove the rest of it. Now the rest of it, that part of the stomach, is one of the major sources of the hunger hormone called ghrelin. Very key. The bypass decreases ghrelin also. The sleeve decreases the ghrelin where, at its source, where it's produced. And there are other effects that the sleeve gastrectomy does also that are metabolic. We kind of like this. It's got a good balance of power and treatment power. It's a little easier to follow up. There's a lower risk of vitamin deficiency. It is not reversible, and there is also, like the gastric bypass, increase in alcohol absorption with a sleeve gastrectomy. The gastric band, and it's been some number of years since we've placed a band for a patient. We still have patients from our program and other programs that we're helping them manage their band. So it's worth learning about. The gastric band, I don't really view it as a metabolic operation. It's more of a mechanical operation. So this is a band that goes around the upper stomach and goes around the top of it. There it goes. Creates a small stomach pouch about the same size as a gastric bypass pouch. Then there's a port, and the port goes under the skin onto the muscle of the abdominal wall of the patient. There it goes. Now, when the band is properly adjusted, as the food comes down, it goes into the pouch and then goes through and kind of expands and kind of rubs on the band. And so we used to think it was just the restriction, but it's also a combination of that tightness and the rubbing on the stomach that triggers a response from the vagus nerve to help the patient feel full. So after a band is placed inside a patient, we do adjustments. We wait about 6 weeks. And this is where I give you a shot in the office into the port, and I can add fluid or take fluid out. That causes the band to squeeze down or relax. And you would think that the tighter you get somebody, the more they would lose weight, and that is actually not the case. If you get somebody too tight, we get maladaptive eating and weight gain, actually. So it's very interesting. So the band is that more of a mechanical rather than a metabolic operation. We do not get the hormonal effects. The nice thing about it is it is removable and it is adjustable. The long-term adjustments are critical. So the first year somebody has a band in, they might need 2 or 3 fills, we call it. Kind of getting it tight, maybe loose until we kind of find that spot that helps the patient. Then the next year they might be good. Then a year later they might need a couple of adjustments, and then they might be good. Then they might need 2 or 3 adjustments, and that never ends because the body is always changing. So we want to change with the body. And most of the time for a long-term band, we're talking mostly about loosening, almost never retightening. The duodenal switch, I kind of view it when you say what's the most powerful bariatric operation? I would say a duodenal switch. Why is it? Because it combines the sleeve gastrectomy and a gastric bypass together, but the bypass is a much longer bypass. So let's see if we can spot that. So here's the sleeve. So that makes sense. And then now we're going to go down and disconnect the small intestine. We remember that. Disconnecting. We're going to bring it up to the sleeve. Good. Now blue is food and yellow is digestive juice. Just like before, they're not joining together. They're still not joining together. Still not joining together. Now they join together. So the difference in this bypass, unlike the classic Roux-en-Y gastric bypass, where the two intestines come together at the top, in the duodenal switch, they don't come together till the end. Now, there's some variations on that. There's also variations where there's a single anastomosis duodenal switch, like there's a single anastomosis gastric bypass, that those variants are out there. But for general education purposes, this is a good way of thinking about it. Okay, how does surgery work? Lots of ways. So it changes metabolic and hormonal systems in the body, including its own GLP-1, GIP, and glucagon. It's what makes it very powerful. It decreases the ghrelin hunger hormone. There's changes in brain signaling. There's changes in the bacteria in the intestine to the good. It does provide restriction with these small pouches or skinny sleeves. Some procedures have malabsorption of calories. That's the duodenal switch. A standard gastric bypass does not malabsorb calories. But all this combined helps reset the set point. And this is what makes metabolic surgery so powerful. We do them either laparoscopic or robotic. And then now we'll talk about endoscopic bariatrics. So this is using a scope down the patient's throat where we can make adjustments to what's going on inside. And so this can help us revise an old sleeve gastrectomy, and it can help us tighten an old gastric bypass. So it's quite exciting. The thing to remember about the endoscopic tool is we're doing restriction, but we're not altering metabolic power. It's kind of similar to way of thinking about, metabolism versus mechanics. So this is quite helpful, but we don't get that metabolic change as strongly as we get, let's say, with a metabolic surgery. Okay, revisions and conversions. Many people get referred to us. Maybe they've had bariatric surgery in the past. Maybe there's some weight regain or heartburn or reflux, and they've been referred to us to consider whether this needs to be revised or converted to a different operation. We uh, have the ability to change a band to a sleeve or a bypass or re-sleeve an old sleeve. We've converted sleeves to bypasses. And then we're especially keen on the endoscopic tool for this, where we can do an endoscopic gastroplasty or revise a gastric bypass with the endoscopic route. Now, the thing about revising somebody is the weight loss results are not as predictable. The primary first operation is the most powerful oomph for treatment. The other thing about revisions is that there may be a higher risk than the primary operation. And so, especially when we're going from one to the other, we may do it in stages. For example, maybe the first thing is to take down an old gastric band, get recovery, and then convert to a different operation. Those things done in stages to help a patient for safety. Okay, what about the risks? The risks of major surgery are standard, include blood clots, and for people suffering from morbid obesity, we give blood thinners to reduce the risk of blood clotting, but that increases our risk of bleeding. So we would rather have a bleeding risk than a clotting. And even on the blood thinners, you can get the blood clots. We worry about leakages, where the bacteria get out through holes in staple lines and erosions, where the band can rub a hole in the stomach. We can get abscesses inside and infections. There's a risk of strictures and ulcers in the stomach. And remember, in any stomach, you can have the risk of ulcer with certain medications. With a bypass stomach, there's a slightly higher risk of ulcer. We treat with medicine. Anybody that's had major surgery has a risk of bowel obstruction because when you go inside the tummy, the body makes scar tissue and the intestine can get twisted up in the scar tissue. And like any major surgery, there are major organ complications and heaven forbid, catastrophic. Those risks are so low, I can't even tell you how low they are. Here's where we talk about ulcers in the gastric bypass and strictures. And there's a risk around vitamin malabsorption, including some medications can be malabsorbed, including antidepressant medicines can be absorbed improperly after a bypass. After a sleeve gastrectomy, we talk a lot about reflux and heartburn and nausea after any stomach surgery. And sometimes after sleeve surgery, it can be the nausea can be very profound, and that usually improves over time. Vitamin malabsorption is only slight in a sleeve gastrectomy versus a gastric bypass where we have more vitamin malabsorption. There are psychologic risks to any massive weight loss, including when we lose the ability to eat that large meal. So eating a larger meal has some psychological comfort to us. And when you physically cannot eat that larger meal, that can be disturbing for some people. Part of the reason why we have our preparation program is so intensive is to get ready for that. There's also addiction transfers. This can happen to the surgery and the medical patients where we take away food and that energy has to go somewhere. There are changes in social relationships around food and eating. Remember, for a sleeve or a bypass, we have increased alcohol absorption, which can be at risk for some people, and decreased antidepressant medicines, and then depression and cosmetic changes in the body are all kind of the psychologic things we consider. You have to remember that this is just a tool. It won't change your genetics or your social environment, and it can be defeated unless it's part of a complete program. And the best outcomes require good long-term follow-up. So, how do we decide about adding surgery? The same way we decide about adding a medicine. We take the risk of the disease and the risk of surgery and then a chance of succeeding without it. How do we decide which surgery? Just like in medications, don't go home and decide which surgery you want. Now, I would encourage you to go home and write down questions about all the surgeries you've learned about and the medicines you've learned about. Because when I see you in the office, it's not going to be to just pick a treatment plan or pick a medicine or pick a surgery. It's really we're going to design a holistic program to try to get a patient to health. Don't let anybody tell you it's simple. Also, there is no magic pill and there is no magic surgery about treating obesity. We'll help you. We help hundreds of people a year do this. So here's our team. And we view it as kind of surrounding the patient. So the bariatric surgeons are myself and Dr. Cortez. Bariatric endoscopy is with Dr. Lustberg. We have a fantastic team of medical bariatric specialists. There are nurse practitioners and our PA. We have 4 dietitians on the team and excellent support staff, all have decades of experience in helping people with the disease of obesity. We have Dave Alt is dedicated, his whole thing is dedicated to quality in our program. The healthystepsinfo.com is our education portal, and on it you'll find a lot of online videos. We have dedicated bariatric psychology. We have a dedicated surgery support group for the surgery patients. And I'm pretty proud of this. I'm the medical director of all of this too, and I'm very proud of this team. Here's our quality. We're accredited, and this is the um, Metabolic and Bariatric Surgery Accreditation Program. We're an accredited center. We carry the highest level of accreditation. Here's our actual results. Note that we have weight loss prior to surgery if you're a surgery patient, and that actually spawned our medical program. So we were helping people so successfully get ready for surgery, and they'd lose weight, and we'd say, why don't we just hold there? And many patients never went on to surgery, and that's how the origin of our medical program. Here's our complications. These are from our MBSA QIP database. So those are our actual numbers, and those will compete favorably anywhere. Okay, we'll guide you. So for the medical treatment plan, we view it as a 6-month journey together. Everybody goes to an education seminar, and then you'll have a consult with one of our medical bariatricians. Note that they're not there to just hand you out some medicine and hope for the best. It's really a comprehensive program. And before anybody starts medicine, we talk about appropriate testing metabolism. Remember the concern about we want to have somebody try to lose fat and preserve muscle, so we do body composition testing. We get nutrition therapy plan going and an exercise plan going, and then we add a medication. Typically, this is a 6-month journey together, and it's pretty intensive. And then once the patient gets going and they're stable on the medication, then they'll follow up with their regular doctor long term. The surgery roadmap, now we're talking about a 2-year journey. Remember, it's a bigger commitment. The same way everybody starts with education. Now you may get a consult with a surgeon and a bariatrician, and then we design a medical preparation, which is more extensive. The lifestyle is the same nutrition, education, and exercise. And then now we're talking about the same, seeing members of our team about every month, month and a half, about 6 to 9 months to get to surgery. And then after that, we do not abandon you. Says that first year after surgery is very important for safety and outcome. So we see people very often. Remember, this is a longer commitment, but then eventually your long-term care will be coordinated at your primary care doctor. This is some housekeeping items about people ask about getting pregnant. We know that children are healthier if they're born after mom has treatment for obesity. We generally want mom to be about 2 years stable at a good, stable, healthy weight before becoming pregnant. Obesity medicines are generally not to be taken during pregnancy. After somebody delivers a baby, we may be able to start medical treatment in 3 to 4 months. We want to wait at least a year for surgery. And then financial considerations. The thing here is most insurance covers some or all of the program. The medications may or may not be covered. I tell people you're going to max out your deductible for 1 or 2 years or even longer. Insurance contracting is out of our hands. That's not my decision or any of our team's decision. These are corporate decisions. Bariatric psychology is out of network. So the only exception there is with partnership health plan. And some insurance will exclude bariatric treatment. They'll exclude bariatric medicines, they'll exclude bariatric surgeries, and there's nothing that we can do about that if that's the case. And some will send people to designated centers. The one thing about insurance is if you have more than one, and many people do, let's say your spouse has one plan and you have a different one, the team needs to know all of it because what you do not want to do is have an insurance company fighting each other about which insurance company is going to cover your treatment, and the patient is caught in the middle. In terms of office etiquette, remember these are long appointments and many people travel far, far away, and we don't have a child care waiting room. We don't have any kind of pediatric support in our offices. So really, we want people to be there and really focus on yourself and obtain child care. One of the other thing that we're really keen on is to avoid people just not showing up. Believe it or not, people just don't show up. And it's sad because we have a wait list of people waiting for these slots. And so if people do what we call a no-show, then they'll go back to the end of the line of that wait list. And sometimes can result in dismissal if you just keep no-showing. The other thing is we also know that people live very far away and we respect your time and gas money. Most of these appointments need to be in person. A few can be remote, but especially with the metabolic testing, we need your physical body because we want to know we actually test you in our office about are we losing fat or muscle, what's happening to the metabolic rate, very important, and we cannot do that remotely. So if you live far away, just let our team know that so that if you're driving here, we want to combine appointments where possible. So what are the next steps? How to join? Between now and when you see me in the office, start working on exercise and activity. Don't get hurt, but if you're not doing this already, start creating the time and space in your life. I have some people that are debilitated by joint disease and other problems, and start thinking about what you can do that you can do and not focusing on what you can't. We like people to keep a log, or some people use Fitbits, whatever it is, to try to help reinforce the idea that activity and exercise will be key to a long-term outcome. Make notes about the treatment. Remember, don't go try to pick your medicine or pick your surgery. We'll do that when we see you in the office. Okay, there's an online survey. There'll be things to do. If you haven't already, get your primary care doctor to make the referral to our program. Enroll in My Health Online. And we tend to get people at least a phone call in the next week or two. It may be a little longer to get actually started. Remember that wait list. And, uh, and we're happy to get you on board. I want people to go to healthystepsinfo.com, and there you can find recordings of seminars and information. And for those of you that your primary language is Spanish, there's seminars there that have Spanish subtitles, and there's a lot of other education in there as well.